Hey everyone, welcome to this explainer. If you're a medical student gearing up for a microbiology lecture or reviewing for your boards, you are in the exact right place. Today, we're basically putting on our attending physician hats for a high-yield, purely clinical dive into food poisoning. It is actually wild how often this exact presentation gets misdiagnosed in the ER as just a run-of-the-mill viral gastroenteritis, leading to a bunch of totally unnecessary workups. So we're going to break down exactly what you need to know to accurately spot it, diagnose it, and treat it like a pro.
Let's jump right into these clinical microbiology notes. We're zeroing in on a super high-yield variant today, non-inflammatory gastroenteritis. We're going to pull out the absolute vital buzzwords here, and more importantly, the underlying pathophysiology. Our goal? To build you a rock-solid mental framework so the next time a violently ill patient bursts through the clinic doors, you can instantly tell the difference between this and much scarier invasive intestinal bugs.
Here's our roadmap for today. 1. Definition and mechanism. 2. The big 3 pathogens. 3. Clinical features. 4. Investigations. And 5. Treatment protocols. Let's get moving. All right, Section 1. Definition and mechanism, the non-inflammatory variant. So, when we talk about this specific type of food poisoning, non-inflammatory gastroenteritis, we're really talking about an intoxication, not a true infection. And hey, this is absolutely crucial. Underline this in your mind. The patient is ingesting a pre-formed toxin right along with their food. The bacteria, they've already done all the heavy lifting while that potato salad was just sitting out on the buffet table. They proliferated, they pumped out an enterotoxin, and the patient literally just ate that toxin straight up. Because the poison is already active, there is zero incubation period needed for the bacteria to colonize or replicate in the host's gut. This perfectly explains why the onset of symptoms is just explosive and incredibly rapid. There's no tissue invasion, no delayed immune response, just an immediate, violent reaction to a poison hitting the gastric mucosa. Moving right along to Section 2, the big 3 pathogens. Know your etiologies. Okay, here is the big 3 matrix you absolutely have to commit to memory for both the wards and your exams. We're looking at Staphylococcus aureus, Bacillus cereus, and Clostridium perfringens. Take a look at the split in those incubation periods. Staph aureus and Bacillus cereus, they hit incredibly fast. We are talking about a brutally short incubation window of just 1 to 6 hours after eating. Contrast that with Clostridium perfringens. That one lingers just a bit longer, taking about 18 to 24 hours to really show up. And definitely pay attention to those classic food sources, right? Because they are prime fodder for clinical vignettes. Staph aureus makes heat-stable enterotoxins that are notoriously linked to improperly handled meats or mayo-based salads. Clostridium perfringens is also tied to meats, specifically those huge vats of slow-cooked stews or gravies that cool down way too slowly. And then there's Bacillus cereus, which is famously and uniquely linked to rice. Man, that rice connection is so iconic, it even has its own historical eponym, a classic clinical pearl you'll see everywhere, Chinese restaurant syndrome. Let's break down how this actually works because it's fascinating. So Bacillus cereus forms these hardy spores that easily survive the initial boiling of the rice. If that cooked rice is left sitting out at room temp instead of going right into the fridge, those stubborn spores quickly germinate and start pumping out a highly emetic toxin called cereulide. And get this, because cereulide is heat stable, if you flash fry that leftover rice the next day, it does absolutely nothing to destroy the poison. So, if your board's question or real-life patient features someone getting violently ill just a few hours after eating leftover fried rice, your brain needs to instantly snap to Bacillus cereus and a preformed toxin. Which brings us nicely to Section 3. Clinical features, recognizing the presentation. So what's the key differentiator to look for the second you walk into the ER room? Well, in these pre-formed toxin ingestions, the vomiting is going to completely overshadow any diarrhea. Since this is an acute upper GI insult acting insanely fast on the gastric mucosa, those enterotoxins heavily stimulate the vagus nerve. Those signals shoot straight up to the chemoreceptor trigger zone in the medulla, and the body's immediate, uncontrollable reflex is just to get this toxin out upwards. Diarrhea can totally happen later down the line, but make no mistake, intractable vomiting is the star of the show here. Bringing the whole clinical picture together, there's a very distinct pattern you've got to recognize. The patient is going to come in with sudden, crampy upper abdominal pain. They'll have that severe vomiting we just mentioned, hitting after a super short incubation period, sometimes before the food is even fully digested. But here is the massive clinical pearl, the one thing that confirms you're looking at a non-inflammatory process, the total absence of a fever. No tissue invasion means no systemic inflammatory response, no pyrogenic cytokines, and therefore no fever. Period. If your patient is spiking a high temp and having chills, you need to immediately broaden that differential to invasive bugs like Salmonella, Shigella, or Campylobacter. You've officially moved way beyond simple preformed toxin food poisoning. All right, Section 4, Investigations Diagnostic Hierarchy. The single most crucial point to remember here when you're working these folks up, the diagnosis is overwhelmingly clinical. You do not need to order a massive, expensive battery of lab tests or inflammatory markers. Your absolute best diagnostic tool is a highly detailed patient history. You really have to play food detective here. Ask exactly what they ate, where they ate it, how it was stored, and exactly how many hours ticked by between the meal and that very first episode of vomiting. That history plus a quick physical exam to check their hydration status is honestly usually all you need. Now, sure, there are those rare public health situations or large outbreaks where the health department might step in and demand a definitive microbial answer. If a culture is absolutely required, there's a strict hierarchy for getting the best diagnostic yield. Step 1, test the suspected uneaten food straight from the source. If the food's already in the trash, well, step 2 is the unenviable task of testing the patient's vomitus. Testing the stool, that's at the absolute bottom of the list for this specific illness, which makes perfect anatomical sense, right? The primary insult and the bulk of that preformed toxin are localized completely in the upper GI tract. But coming back to the reality of everyday clinical practice, these cultures are rarely done and almost never actually needed to manage your patient. The turnaround time alone makes them clinically useless for the acute phase. I mean, by the time a lab culture comes back 3 days later, a patient with a 1 to 6 hours self-limiting toxin illness is already 100% recovered, eating a normal diet and chilling at home. Finally, Section 5, Treatment Protocols, Managing the Patient. Because this illness is driven by a preformed toxin that basically just needs to run its course and get expelled, the treatment is beautifully straightforward. It's purely supportive. You want to focus entirely on replacing what the patient is acutely losing and just making them comfortable. So that means pushing intravenous isotronic crystalloids like normal saline or lactating bringers to rapidly fix the hypovolemia from all that vomiting, and at the exact same time, you want to hit them with targeted antiemetics like an ondansetron push. That'll suppress the medullary emetic center, shut down that vomiting reflex, and finally give their highly irritated upper GI tract a chance to just rest. And that brings us to a major clinical trap that you absolutely have to avoid on the wards. Guys, antibiotics have zero role in this type of food poisoning. Zip. None. Think back to our core mechanism. The patient isn't sick because a bunch of bacteria are actively multiplying in their gut. They're sick because they swallowed a preformed poison. Dropping a nuclear antibiotic bomb on their natural gut flora is going to do absolutely nothing to neutralize the toxin that's already burning their stomach lining. It's completely unnecessary, it drives up antibiotic resistance, and it exposes the patient to nasty side effects like C. diff, all for literally zero therapeutic benefit. So we've nailed down the intoxication mechanisms, met the big 3 pathogens, mapped out the clinical signs, and locked in the supportive management protocols. The real question is, the next time you're faced with a violently ill patient with rapid onset vomiting and no fever, will you remember the timeline, take that detailed food history, and confidently hold off on writing that antibiotic prescription? Keep these high-yield microbiology notes locked in, and you are going to navigate these common emergency cases with total clinical confidence. Thanks for joining me on this explainer, and keep studying smart.